Welcome to the Soul of Medicine. Welcome, everybody, to another inspiring episode of the Soul of Medicine podcast. I'm your host, Dr. Kay Corpus, along with Rob Kress. And today we have truly special guests who embody the kind of compassion, holistic care that this podcast is all about. So please join me in welcoming Dr. Jessica Wood and Dr. Ryan Wood, the co-founders of Forefront Therapy in Evansville, Indiana. This power couple is revolutionizing the way therapy is delivered in their community and beyond. As occupational and physical therapists, they've built Forefront Therapy on three core pillars: one-on-one care, a commitment to education and research, and a passion for making therapy accessible to all. Their work is a shining example of what it means to truly see and treat the whole person, not just a diagnosis. Jessica, an expert in pediatric occupational therapy, and Ryan, a specialist in orthopedic physical therapy, have dedicated their careers not only to providing exceptional patient care, but also advancing the field through research and education. Their work has earned them international recognition, including being named a Specialty Center of Excellence for treating patients with Ehlers-Danlos Syndrome. Today, we'll dive into their inspiring story, the unique approach that sets Forefront Therapy apart, and how they're making a real difference in the lives of their patients and the broader community. With their shared passion for holistic, individualized care, Jessica and Ryan truly embody the soul of medicine. So let's get started on this journey with two remarkable healers who are changing lives one patient at a time. Welcome, guys.
Thanks for having us.
Thanks, and thanks for that, Kate.
Yeah, you're welcome.
Very nice.
You're welcome, and you all deserve it. So let's just start from the beginning. Jessica and Ryan, can you each share a little bit about your backgrounds and what led you to start Forefront Therapy?
Well, I'll start. And you know that I like to talk, Kay, so I'm going to try to
lovely.
this through. Well, I knew I wanted to be an occupational therapist in high school, actually. My cousins were both born with epidermolysis bullosa, and so it's a rare genetic skin disease. And so I found out about occupational therapy then, and I loved just how it can help specifically kids at the time to still be able to be kids and play. And then realized that, no matter what limitation comes their way, that they can still be able to play and be kids. I went to St. Louis University, it's a Jesuit college, and felt very strongly about the Jesuit mission. And that is where I started learning about sensory integration, which is now my specialty. I did a lot of volunteering with a lot of research projects and a postdoctorate, an OT that was getting her postdoc at the time, and really volunteered with her and spent years doing that before I became the dean's research assistant, and her research was all in sensory integration. So it kind of set me up for really loving and enjoying not only occupational therapy, but the research behind it and how important that is to kind of push our profession forward. And then that's where I met Ryan and realized that we had very similar passions to help people and to see people as what they were, just everyone is here living their soul's purpose, and we're just here to help them to be their full self.
So I'm originally from north of Chicago. I went to St. Louis U with the intention to become a pediatrician. I played hockey there, ended up getting hurt, was really looking at, what are my personal goals? How long do I actually want to go to school before I can start a family or before I can start my professional endeavors? So had no idea what physical therapy was. And when I got hurt in hockey my freshman year, it really introduced me to it. And then really kind of found a love for the time that we have to spend with people with healing, the spread of different regions and specialties within our field. And also for our program, it was a 3+3, so 3-year undergrad, 3-year doctorate. So to be able to get out with your doctorate in 6 years and start practicing really sounded nice at that time. Like I said, I don't have the wonderful, mission-based, inspired story that my wife has on kind of why I became a PT. St. Louis U definitely helped shape our lives. And we both were blessed with great families and great upbringings that really did help us look at everybody as an individual and never put ourselves above somebody else, which then I think really inspired how and why we started Forefront with the mission. So we did traveling therapy for a year after graduating, bounced around Texas to pay off school loans and see the country. Then we went up to University of Chicago. I was able to do an orthopedic residency up there at University of Chicago. Jess worked in schools for a year, then was the only pediatric OT at Commerce Children's Hospital, University of Chicago. Then we moved down to Evansville because we started a family, and my wife has her roots locked into Evansville, and we were going to give it a go to start life there. So then I worked out in Owensboro, Kentucky for 2 years because I really, at that time, could not find an organization that I felt like was a good fit in Evansville. So I decided to do the 45-minute drive, found a place where I could at least treat one-on-one, where I was not treating two people at once. There were some challenges with continuity of care and just some organizational culture challenges that really kind of pushed us to finally then pulling the trigger on starting Forefront. And that's kind of what led us there. You know, one of the biggest issues that I always had when I was wanting to start, my professional career in Evansville was interviewing and asking organizations, downtown and on the south side right now, there are no clinics. Can you let me know why that is? And resoundingly, I was told because of the fact that it's really not profitable. And these are large companies, lots of clinics. And for me, I respect that absolutely from a business mindset. But from an organizational culture and more of an ethical standpoint, I really wanted to join a group that allowed me to be able to serve the entire community. Because really, neither of us ever had a dream of starting our own company necessarily. You always wanted to work with kids there if and you're willing, but.
Yeah, I always knew that I wanted to bring sensory integration back to Evansville and to this area because I saw, being in St. Louis, just how much of an impact it was making with children. And I think I realized when I would come home and we would see family friends and kids that would really, really need it. And I was just having a hard time telling them where to go because, who was doing AIRS, sensory integration. And so when we moved back, I taught at University of Southern Indiana for 8 years before leaving and being full-time in the pediatric branch of our clinic. And that was amazing. It was a great experience to, able to do a lot of research and do some of those parts, but just seeing that the need was there to be treating the children. And that's just also really, really grown as well.
I love that story. And, and I think knowing you two also a little bit personally, I think it makes sense that you started your own clinic just because I think you both lead very much from your heart space. And you're very, I think you have brains and all of that, but I feel like what really motivates you is even a heart-centered entrepreneur to kind of figure out how do I serve as much as I can, make the biggest impact I can, doing the best work that I can, which is not always out there in corporate, for whatever reason. And I feel like you both have always led that way with your heart, and both of you together are truly this, I think, power couple to be able to serve the community in that way in different ways. Do you find that's true that, I know, Jess, you do have a bleeding heart and it's so sweet and I love it. And I love how you're using it.
Thanks. Yeah. I would definitely say, when I think back, we were probably had our Forefront Therapy, our for-profit clinic had probably been up and running for maybe 2 years. And then all of a sudden, Ryan would just wake up in the middle of the night and he would just start taking notes. And he was doing it a lot. And I was just like, what is going on? And he's like, I've got to figure out a way to treat these people who have Medicaid or who are uninsured or who, what about the homeless? And they're just in pain. I've got to find a way to treat these people because right now with a small for-profit clinic, I just couldn't treat them all day and stay in the black. How can I do this? How can I do this? And so it truly became something where I ended up getting him a notepad that had his initials up at the top because I was you're waking up so much in the middle of the night and just taking all these notes. And it made me realize that leading up to starting the nonprofit and all of the years of prep that it entailed, we had people asking us like, with the energy that you're putting towards the nonprofit, you could open up two more for-profit clinics and be making money, like a lot of money off of that. Like you're putting so much of your focus towards this nonprofit. And I think it truly is that. It's like, we're here to, like, we feel like we have these special talents of treatment, and it shouldn't just be only given to those who have the money to pay for it. Because, if anybody's in pain, they should have another option other than just pain meds. And so I think truly the nonprofit, I was there as a support for sure, and I believe in it strongly, but it was definitely, Ryan's baby, waking up in the middle of the night and thinking, how can I treat the full community? And even since then, some of the things that it's just a constant work in progress. Like, hey, we've got a large population right now of only Spanish speaking people. How can we help? Who can we pull in from the community to help us here? What courses can we offer our therapists to help them feel more comfortable in this? And so, yeah, that was a very long answer to a question that, I definitely think that it's led from the heart for sure.
So physical therapists coming out of school, and I mentioned that my daughter is pre-PT, what would your advice be to, these young adults coming out, and because she's already thinking like, oh, I should go work for this person and this person. And I'm like, well, why don't you just see, and, maybe you can start your own thing and follow your heart. And what kind of advice would you give?
I think the best thing that we elected to do traveling therapy for a year. Both of our, like you said, we have amazing families that covered so much of our, student tuition and expenses. But we did personally, as a couple, we came out with about 6 figures, right, of debt. And our focus was, okay, let's see the country. Let's go do traveling. We're going to be able to make a lot of money because you get paid more as a contract worker, and we'll pay off some debt. I can tell you that looking back, it was a great experience for us. It's a very hard position to do something like that for your average new grad. I didn't mean that as something that we are better than somebody else or anything like that. I think it takes a person to be able to have some self-confidence and roll with the punches and have really grounded clinical rotation experiences as well to be able to excel in that sort of framework, because most of the time you're in a position where you're not getting mentorship. So then the next step in my personal career was seeking that mentorship and that expertise. And that was the best thing that I could have done clinically, to be able to do a really strong residency where I joined a department where I am by far the least experienced, lowest intellect. You just soak everything in. There is this push for a lot of our new graduates right now to open up their own practices and cash-based practices. I think the gap that a lot of people are missing is, even though you're graduating with a doctorate, it's a doctorate in 12 different fields of physical therapy, which means you know enough to get your degree and pass your boards. You're not necessarily coming out providing excellent care. So my biggest recommendation, if you're really going to be patient-centered, you're always going to be able to start your own practice, right? For your average person coming out with your doctorate about 25, you have 40 years before you're on average retire. So find an amazing program, find amazing mentors, and really lock yourself in clinically, because what that'll do, in healthcare, we are our own product at the end of the day. How we deliver care, we are a product, or a service delivery entity. So if you can get really, really good at what you do, your likelihood to succeed, if then you want to open up your own practice, is going to be just that much more, right? Sharpen your tools sort of deal. So that's my biggest recommendation for somebody coming out of school. I would not recommend to open up your own practice right away. It is so much work. The highs are so high, the lows are so low with entrepreneurship. It is so challenging. You've got to figure out patience. And there's enough vulnerability trying to convince the community that you can do a good job, that you're also then trying to convince yourself that you can do a good job when you're coming out of school. Because your average new grad is a wonderful, very smart, insecure mess that needs refining, and that's in every single field. That's why we have internships and residencies and things like that. So that would be my strong recommendation.
And I would say the same with occupational therapy. We have fellowships. It's called residencies in PT, and they're fellowships for OT. And I would say do a fellowship or find a really awesome mentor that is going to just pour into you. Mm-hmm. And I think it requires a mindset shift. I think sometimes some people like Ryan and I, we were like, give us the mentorship. Like we were always kind of in that soak it up.
Well, there's a reason our number 2 core pillar is education and research. So anybody listening, take that with a huge grain of salt, right? I mean, for us, the smarter you can become and the better we can do it, everything is then going to be succeeding after that on every level.
And I think probably the cool thing about therapy to me is that the stuff that you learn in school, and I'll say it, as teaching in a program, that was a great program, for 8 years, we can only teach so much in school, but like, that's only like, 1/15 of what you can do as a PT or an OT. Like there's just so much more and it's so fulfilling. So, figure out what it is that makes you light up on the inside, but then get all the mentorship because you'll just love your profession even more. And I think it helps with burnout. It helps with all of these things that we're all, struggling with in the medical field. If you can find the thing that makes you excited and then find somebody to mentor you to help you to even keep growing from that place. So,
and if you go cash-based route, if you open your own practice, it does make it cleaner. You don't have to worry about insurances. You don't have to worry about billing and claims on that level. So there is some ability to bypass some of those business hurdles, but there's also then you hit that level where in most regions, you can only grow a cash-based practice so large. So it depends if you want to keep your foot in the door clinically for X amount of years, or if you have a vision of growing a team. So I think that also depends on what your personal and professional mission is on how you open up a practice. Because, one of the top reasons for burnout in healthcare is isolation and loneliness, right? So if you're opening up then a standalone practice, there is that balance then that you're in it. At times, you're in it alone. Even if you're in a huge group, you still feel alone at times. So that's the pros and cons a little bit of starting it up right after school.
Rob, I know you were squirming in your chair there. Did you want to ask a question regarding mentorship?
Well, actually, this whole thing is so fascinating. I've taken so many notes already. So I appreciate this, but let me throw a question out there. So you started with your for-profit. And then after 2 years, you went into the non-for-profit. Obviously, that had strong meaning for you. And I mean, you were driven by that just to start writing. But what tools or benefits did you gain from your not-for-profit that has actually paid off, or I should say, supported your for-profit clinic? My guess is these things, it's like rise and tides, and they've grown together in some ways.
The social perception in the U.S. is that a nonprofit is not profitable. A 501c3 entity is a tax-exempt entity. At 2-year mark, I was doing my Master's of Health Administration, and I was really trying to learn about, I was introduced to social enterprises, and I was, where you can have a for-profit entity with a social justice, push. Tom's Shoes is a perfect example. For every pair of shoes you buy, they ship a pair of shoes out to Africa or somewhere else in need. So that started getting some wheels turning. And then, you learn about hospital entities where the average for-profit hospital is making 18% less than your average non-profit hospital. And there's a lot of various reasons. They have foundations, they have tax privileges, state and federal income taxes waived. So there are different ways to serve the community that can be achieved in different models. And Jess was right when she brought it up earlier that as a small for-profit, we have no leverage to negotiate fee schedule contracts with commercial entities. So they're going to pay us a baseline rate on average 40 to 45% less than, let's say, a hospital gets for the same exact service. So we're looking at, okay, Medicaid, Medicare, we're losing significant money every time we're working with somebody with that type of insurance. And the uninsured, well, you can only write off so much. And we have 4 children. We're young. Yeah, I mean, we want to help all, but at the same time, we have to make sure that we're keeping, fiscal responsibility for our family as well. So the nonprofit, we actually took about 2 years of a lot of different courses to figure out, like, how do you run a nonprofit? What are the steps to get there? You have to do a board. What is grant writing? How do you report? I mean, it was 2 years of intensive learning. And then another about 10 months, Old National Bank here in town, and this may be more than what you're asking for, but Old National Bank sponsored us. We had 96 hours of free legal service. We were a DEI initiative for them. So they helped us get our program off the ground. And what we did was we actually split our organization, and anybody that had Medicare, Medicaid, or were uninsured or in the future now underinsured, we actually serve them in our nonprofit entity. Anybody with commercial insurance, or if they're cash-based, but they make over 200% above the federal poverty line, we serve them in our for-profit entity. And then our pediatric right now is also for-profit side. So that's how we split it and why. We also do a lot of community education. We've started some research through our nonprofit. So having a nonprofit entity, we do not have to partner with a university or another nonprofit as a fiscal agent in order to write grants. So we've actually gotten now over $1.5 million in 4 years for our nonprofit side, helping with our build out, helping with programming support, a lot of ways to get the community to then partner with us, and so I always say, I learned this through Welborn Baptist Foundation. They gave a year-long nonprofit courses, fantastic. But there's 3 main ways where you can grow partnership with the community to serve, cause. First, you have expertise. We know what we're doing well. We want to deliver it, right? The second is financial resources. So maybe you don't know what you're doing, but you can partner and give financial support for serving that mission. And then the third is time. And so maybe you don't have expertise, maybe you do not have money, but you can donate your time in one way or the other. You can go to a soup kitchen, you can do different things. So you can help clean. I mean, there's a lot of ways to serve. So those are the big 3. And that's what's, I think, inspired us to grow partnership in our mission with the community as well.
That's awesome. That's fascinating. I mean, it really does show how a lot of people, for me, for sure, I don't know the ins and outs or the depths of what nonprofit is and what goes into it, but it does show that the power of it and how it's almost a multi-way direction, right? It's just not a one-way path. And I can see how that can actually support and pour into the profit section or your brand, I guess we could just say your overall brand and who you two are, which is very powerful. Yeah.
Thanks. And that has absolutely, I would be completely lying if I said that our nonprofit does not help our for-profit from a branding perspective. And we actually have the majority of our clinicians actually work in different, multiple clinics. So they'll serve maybe 2 days a week in the nonprofit and 2 days a week in the for-profit side. So I actually think as well that does help because then they're part of that social cause. There is some benefit on that side. And the nonprofit serves a pretty solid positive for differentiation in roles. So if somebody's really inspired on a certain program, we can find a partner, write a grant, and execute it. An example we partnered with the Arthritis Foundation, and Welborn Baptist Foundation gave us a $23,000 grant to do 6 different community educational seminars and programs, partnering with different nonprofit entities, but we were able to pull some of our team members in to take lead on that. And that was part of then their paid week. So then it's not that you're 40 hours a week clinical, maybe you're 38 hours a week clinical, but you're also getting paid for 2 hours a week to serve social cause. But I also do not want to be misleading because that nonprofit, I mean, it's harder to operate by far than a for-profit. I mean, it is so much work. So I've had people call and ask advice about the nonprofit side and like, I think I want to start one out of school. I'm like, okay. I'm like, not to be like this naysayer. There's certain people probably could and could do it well, right? But I'm talking like 1% that could do it right out of school and do it well. It took me so much work and I think I'm somewhat sharp. So it took so many years of learning and growing and community partnership. I mean, I was serving CEOs when, in our for-profit side, and people don't even really see, it's like, this is 8 years of growing a community network where then when we're writing grants, okay, they know who we are because then they're bought in on our mission and our culture and why we're different. So it took a lot of, divine intervention, but also a lot of sweat equity.
Yeah, absolutely. And, I think one cool result you just said is there's an alignment of values through your whole organization from top down, from you all to your other practitioners. And that itself has to have a tremendous drive to it. So that's awesome. Thank you.
So that is so cool. And I agree with that. I mean, sometimes it looks glamorous from the outside because you're like chill right now and everything is good. And it's just like, I want to be like them. And it's like, no, dudes, this took like a long time. And we're the same way in our practice. And, Rob too mentors a lot of pharmacists. And even I have nurse practitioners and med students are just, I like functional medicine. I'm like, that's great. You got to practice it. You're not hireable at this point because you think it's cute. Like you got to really get in there. And also those nuances in clinical practice that you have to learn too on not just, I don't take insurance, but even dealing with patients and all of that. And just all the back stuff that it's not just going in and prescribing supplements, and have a nice day. There's a lot of stuff behind that. And also leading your community and things that the buy-in isn't quite there yet, which does, take a while. So, you guys are like really breaking through the ceilings and helping, people like my kid go in and hopefully do it a little bit, faster because you guys are doing. So I think that's really great.
Well, like you even said, I mean, think about all the lessons you've learned and likely experiences of burnout that you had to overcome when you're providing so much investment in other people. And I think if you don't have those skills coming out of school yet, how can you do that successfully and not burn out within 3 years? There's a lot to that.
Absolutely. So just to pivot, can you guys discuss your approach to viewing patients as holistic, not just diagnosis and symptoms, and how do you incorporate this holistic viewpoint in your treatment plans?
My path in holistic approach, I think I've always really found, I don't like humanity at times and what we're doing to the world, but I do find individual humans very intriguing. I really love the psychology behind engaging with somebody and how do I get myself onto their level to gain their trust? And not from a manipulative standpoint, but from, I think, I'm being my authentic self and how do I get them to feel comfortable quickly? And I really realized quickly in my career how big of an impact my dad had on me, even that in sports, right? In sports, you have to deal with all types of people, straight A students, DNF students, dropouts, it doesn't matter, right? So sports gains, I think, such a level of understanding when you're winning, how do you handle losing? And it gives you, I think, a sense of empathy because then you can know what it's like to push through so many pain points. And so I do think that. And then my father, he it's a long story, but he started, from a good family, but he started at a company as an intern, worked his way up, really actually stole the application out of somebody's office to even get the internship because they told him he wasn't a good fit. The counselor did. So he broke in and they stole the application. He submitted it. He actually got the position in Chicago. He's from Central Illinois and worked his way up the chain and ended up when he retired, he was vice president and he was head of the entire IT group for this international company. And he told me one of his keys to success, other than, working his tail off, was he could talk to anybody. And he had respect for everybody. He knew the names of the custodians in this international group, and he would understand how the small details matter so much when you're actually engaging and how important relationships are. So I think that led to then, long story short, that led to me understanding how the human the individual is the one that's in pain, not their shoulder, right? And then the more we learn through school, the more we're learning. Even, there's a big push for psychologically informed practice and pain neuroscience education. And I'm learning even now, 12 years into my career, I'm learning the better I get, the less I touch people, the more I educate, the more I put them as an advocate, and really I'm teaching you how to heal yourself, not the other way around. You're not here for me to heal you. And we tell that to people every day. I'm here to help you learn how to heal because I want this sustainable. Our practice is not a practice where it's a quick hit. We give you these 4 exercises and you're automatically healed, or I pop your back and we do these mobilizations and you're going to be perfect. Our practice really focuses on the whole person, because if we can heal you or teach you how to heal sustainably, well, then you're not having to come back to us in 6 months saying, no, PT didn't work. Let me try this again. And everybody needs a tune-up now and then. But what it does do is they receive such good care that they then want to tell their friends and family. So our patients are our number one referring providers because we focus on the whole person.
In pediatrics, so our big push, something that we feel very strongly about on the pediatric side of things, is that one of the 2 main caregivers is in every single therapy session with the kiddo. And I know that was a little bit, you might be like, yeah, that of course. But actually in the past, it's been, where people bring their kids and the therapist takes them back, and then they bring them back, an hour later and say, they did great, and what we've realized is that when the parent's in the session with the kiddo during therapy, we always talk to the therapist about, like, guys, we do 20% of it is like you hands-on, but 80% is hands-on and educating the parent. So you got to like really be thinking about every single thing you do. You set up this whole activity, this whole obstacle course, and you're doing it. But you should be the whole time looking over at the parent being like, remember when we talked about bilateral coordination? This is bilateral coordination. Remember when we talked about this? This is what you're seeing right now. Because then they can go home and do it with the family, maybe incorporate it into their other children too. And I will say that even giving talks, I like to go and give talks to teachers or moms groups, or, they'll say, gosh, even just seeing these kiddos with a different lens, seeing their outbursts or seeing this behavior. And now if I put on, my sensory lens and look through it differently, I feel like I'm disciplining my kid differently now, or I feel like I see them differently now. And I think that that's so important to looking at the whole of a person. I think also it's always about digging in. So I think it's really easy for somebody to give you a symptom and for you to be like, okay, let's go right there. But is that where the symptom originated from? Or is that just a symptom of something else?
Cause and effect.
So like, we're all about like, let's keep going. Let's like dig a little bit deeper. Let's make sure that we do the proper interview and the proper data finding to get down to the bottom of it. And sometimes when you get down to the bottom of it, you say like, this actually doesn't have anything to do with, you're worried that they're not getting enough food and you want us to try to get more food in their mouth. But actually this is like deeper, and let's start there. And then let's work our way to the feeding thing. I think too, that comes with mentorship too, like being able to know all of those things and how to dig in and knowing what to ask. And
we always try to figure out the cause. We tell people all the time, yes, we're going to treat your pain. Yes, we're going to treat the issue. We're going to respect that you're hurting, but there are reasons why you're hurting. And there's reasons why you failed at 3 other PT groups and 2 chiropractic groups, and pain meds aren't working. What is the real cause on why this is occurring? And I will say, that's one thing about our professions that gives us that capacity, because and why we started our practice with our first core pillar is one-on-one, evidence-based care, is because if we shared patients all the time and they bounced to 3 or 4 different therapists, or if we were treating 2 at once, how do you hear somebody's story, or how do you see the nuance on session 4 if you can just tell they're having a bad day? How do they even feel vulnerable or trust you and safe to open up with a story of maybe abuse when they were a kid, or current abuse, the trauma that we all hold. And let's call it as it is. Chronic pain is insidious PTSD. So even understanding these aspects allow us, the more I come in practice, I know some people that I've worked with in the past, and they've gotten into maybe the second half of their careers, they start to become a little hardened and a little bitter, a little resentful for the same story from the same day on a different person. I think the reason why we love education so much is because the more we learn, I think the more empathy we're developing and the more patience for the patient. Like malingering, where people are making their pain up and seeking attention, I genuinely see this so much less, or I'm expecting it so much less than when I did, in the first half of my career. So yeah, that's the whole person can give you that.
I love that. And, we practice, trauma-informed primary care, and to have that background of understanding where this pain is coming, it's deep, and so my question is, so knowing that as a physical therapist or an occupational therapist with your scope of practice, how do you handle that when you really know what's going on? It's probably some kind of complex PTSD going on, or something locked in the tissues in that way. So how do you function clinically in that situation, knowing that, it may be multiple visits, or are you functioning as also this safe space? Because I think that is also it's not even the modality, but it's being the safe person to hold that space for them. And then, the pain actually sometimes tends to release on its own, just because they were given an opportunity to release it in a way that's, they don't have to hold it down anymore. So, and I'm also, because we get this a lot with people that we mentor. It's like, well, I'm not a therapist. Like, I'm not going to go there with them. It's like, I'm just a pharmacist, and this is not the place to talk about that, or this is beyond my scope. Or when it gets uncomfortable for the practitioner, that, oh my God, the trauma's coming up. This is opening Pandora's box, and I've got 10 patients in the waiting room right now, and I can't deal with this right now, which is coming out as a new resident. I know that kind of like thing, scarcity of time. How do you handle that, and how do you teach that? How do you handle it as clinicians, and what do you, how do you mentor that for your students or your colleagues? How to handle those deeper issues?
So I think it's a hard balance to walk. And I think I found my own career path where, okay, I got very good at realizing when trauma is a big part of the pain pie. And the fear, the fear avoidance where they're not going to do something, or the pain catastrophization where all they can focus on is the pain. The first thing they think about when they wake up in the morning is the last thing they think about when they go to bed, right? Where it consumes them. A lot of these individuals, sometimes even acknowledging that it's a part of their pain, you don't have to be the one to process that for them, right? You don't have to be the one that processes that trauma for them. But even acknowledging that it's a problem, it's funny when it really can release a lot of then the burden and the hold that it has on an individual. And then that too is where an interdisciplinary model is so important, because I do not have the tools to, get their, full trauma history talk about sexual abuse, I know where my limitations are. So there was a time where I probably crossed that boundary, and it was maybe 5 years in, where I was spending way too much time in a session trying to open this up and figure this out. And then I realized, I realized my efficacy was less. And what I was doing was I was actually unlocking this trauma for them, but not then having the tools to give them resolution. So that was as much dangerous as anything, where I'd give them the Body Keeps the Score book, and they weren't ready to read it. I didn't realize it. They read it and they had a full psychological meltdown. But I'm a physical therapist. I knew that you had trauma, so I thought I'd give you information, and I thought it would help. So that's the aspect with understanding, I think, psychologically informed practice. What is our specialty? What role do we play? How much do you want to unlock versus how much do you want to make sure that they can see that it's a part of the problem, and then connect them then with the right person to resolve that problem. Don't just say you have an issue and good luck and slap them on the butt on the way out, right? So I think too, it's connecting services and having a multidisciplinary approach. But I think understanding for me, the neuroscience to teach them, hey, the same areas in your brain that process pain are the same areas that process trauma, bitterness, anxiety, depression, right? It's the same areas that light up. It's congruent. So even teaching them these different aspects, it really helps them become smarter about their pain. They start hurting. Their first thought is, oh, shit, I shouldn't have done this movement. I'm going to hurt now for 5 days. Their first thought is, okay, how did I do this movement? What sort of stress is actually going on in my life? Am I eating well? Am I sleeping well? Am I doing my exercises, right? So what is my pain puzzle actually showing me? Because at the end of the day, pain for me and for everybody is data. It's an alarm system. That's all it is. Danger, danger, something's wrong. Either you got hit with a bat and it hurts, or you're holding trauma then, or you're not eating well, so you're having systemic inflammation that's then causing some, secondary issues down the road. So that's where it's not just treat the pain.
Yeah. I think for me, it's interesting because with my specialty being in sensory integration, they say there are kids who are born with sensory integrated dysfunction, and, they're trying to dive into it more in the research. Is it epigenetics? What is it? But then they know that there are kids who receive trauma who then have sensory integrated dysfunction. And again, going back to like the Body Keeps the Score, right? It's like I feel like Dr. Portis, he's just starting, and Dr. Vanicold, to dip their toes into these kiddos have these sensory things going on, right? And I think that what we find with sensory integrated dysfunction is it's not just that their sensory system is different. It's not just that they don't like tags in their shirts or textures are funny when they're eating food. It's that they also have dyspraxia, so difficulty coordinating movement. It's oftentimes in their eyes and visual motor coordination, but it's also in bilateral coordination. And so I think for me, the more I dive into learning more about pain and trauma, it's just really interesting how, EMDR, the person who invented the EMDR, when you read her book, she talks about the importance of, doing essentially bilateral coordination, essentially two hemispheres of your brain talking through your corpus callosum, and how can you integrate, have those messages move back and forth seamlessly. And I think it's interesting because that's a lot of what we do in occupational therapy is bilateral coordination. And how can we, again, also do that? And so, we say before you go to bed at night and you're processing the day, let's do our bilateral coordination types of things. So I think it's interesting how these things kind of can go kind of hand in hand, trying to work through and trying to process through some of the trauma while also helping them with their sensory integration. Yeah, I think some of it is it's working and we know it works. But I think for me, I'm diving more into the why all the time.
So, I've done some work with Gabor Mate, who has his compassionate inquiry psychotherapeutic model. And his very first, this is going back to as a practitioner, his very first tenet is empathetic abiding presence. And I think that's as clinicians, we're like, okay, our modalities, and this is what we can do, and we forget that one piece of just being to be with that situation and maybe even being quiet, not having to fix it, which is, as healers, we want to automatically go in there and give them all the things, and that has been my biggest lesson of just being able to be with that, because that's uncomfortable, because I don't want it that they're hurting, and, I want to go beat up whoever hurt them and, all those things. And it's to be able to sit with that with them, I have found to be very powerful as well. Rob, did you want to say something?
No, just completely in agreement. I mean, the way this is all going together, and, one thing that really stuck out, the better I get, the less I touch people. I mean, this is coming from physical therapy. I think that's pretty profound in the holistic model of healing. And, as you're alluding to Gabor Mate, John Sarna is coming to mind, right? And like all that role and how it all comes together. So I'm just really enjoying this conversation. Thank you.
Well, it's true. I think I know that I'm clicking and firing on all cylinders when at the end of the first evaluation and they're walking out and they kind of pause at the door and they turn around and either they have tears in their eyes or I haven't been heard like that. Thank you. Or I feel hope for the first time in 5 years, and that is powerful. And I think so much of that, like you're alluding to, the ability to be present and actually see them for who they are, that is a strong skill. And I guess then going back to our previous discussion, how many new graduates can do that well? I would argue 99% cannot. They're so worried about having their shoes tied well and did I type my note up and what am I billing? And did I put my hands in the right position when I assess this, shoulder? There's just so many factors there. I'm sure there are some people coming out of school that can hit the ground running, but they are probably ones that have either been blessed with a God-given healing talent or they've already had a ton of mentorship. Like I'm sure, Kay, your daughter probably has some innate ability just being, your offspring. And I'm sure she's probably learned a lot of ways to listen and to heal and to hear that will give her some, obvious advantage.
I'm totally cracking up right now, Ryan, because I don't know if she's going to listen to this podcast, but I don't think she really likes touching people. So this is just great. I was like, how are you going to be a physical therapist? I'm like, oh yeah, you can totally be a physical therapist now, like Ryan.
Well, I still touch people a lot. When I say I touch them less, I still touch them a lot. I just think you find this boundary of you're sitting here trying to let people know that I'm not healing you. I'm going to do this technique to open a door. You're going to have to walk through it and keep it open, right? If you're not doing your end of the piece, the door is going to close. You're going to have to keep coming back to me, and I'm going to have to do the same technique to get this issue. I have to calm the tissue down. I have to get them that mobility back. It's up to them to maintain it. And I think that then I see them less relatively also because I'm getting better at figuring out the why quicker.
I also feel that when we hold people and patients to that standard, not the lowest common denominator, but their highest common denominator, and meeting me halfway, you can do this. Here, I'm giving you the tools. Now you do it. That there's something that happens in that, they believe in me and they don't see me as somebody who can't do this, but somebody who can. That's really, really empowering. So, I think the touch is so symbolic. There's a physical touch, but there's also this energetic sort of holding of that too. So I feel that anymore to be a really good, effective healer, we have to use all of those faculties, not just our head, our hands, our stethoscope, and all of that, but bringing online, this is why I love both of you, whether we articulate it in that way of what we're using, those intangible gifts that we have that we're using, like all of that coming online, I think makes the whole healing interaction possible, and you guys are good examples of that. I've tried to be that example for my daughter, but, having that more in, trainings, I think is important as well.
We're all energetic and magnetic beings, right? And we did Reiki training to try to even figure out, not that we're actively practicing Reiki in our practice, but understanding that there is a transference of energy regardless. And actually, we did it, number one, to learn because we're geeks, but number two, even how we protect our own energy. That was like a secondary layer of like, okay, let's understand energy flow better so that we're not getting burnout and somebody's sucking our energy dry, because I can feel them in the waiting room vibrating, right? I know it's going to be a bad day. Like the atmosphere is buzzing. And also, I guess to key back into the whole discussion of new grad, if you're not grounded and stable, what sort of energy are you putting into somebody when you're hands-on, right? If you're not locked in and you're insecure, what happens with insecurity to our energy, right? So what type of energy? You're giving them frantic energy. So it's not going to then help. Because, yeah, we're working on mobility, but we don't have necessarily the research, but there 100% is a transfer of energy. It's impossible to ignore. And I think the best moment in the future of our profession is when the research connects energy with biomechanical, with psych, right? That's where it's all going. It's going to get there. But that goes back to then grounding, new graduate. It takes mentorship to even to have confidence. It makes you more stable. The more confident you are, the more stable you are, the better your energy is going to be.
Absolutely. And this is actually the crux of why I invited both of you on, because there is that I think is missing from those interactions, especially as a physical therapist or even as a clinician, those of us who have the license to touch somebody and not to know that, that's not just for Reiki people or whatever. That's brilliant. So thank you so much for sharing all of that. And if we have a couple more minutes, I just wanted to ask you, talk about your EDS specialization. You are a specialty center of excellence for that. Could you, and Ryan, I remember having this conversation with you years ago, and it's cool that you went on to get this specialization. I see a lot of this in my practice as well. Could you touch on what this is, who you see in your practice, and how you're helping them with hypermobility and EDS?
Yeah, I'd be happy to. So the Ehlers-Danlos Society is an international society. They're fantastic. They are so patient-centered. I've been so impressed with them with every single interaction that we've had. We could probably have a whole podcast on kind of how this all came about, but long story short, so folks with Ehlers-Danlos syndrome or generalized hypermobility syndromes, the hypermobile spectrum. So for folks listening that aren't aware, it's a connective tissue disorder which collagen, it's a protein. It's essentially more flexible, and it's in nearly every single structure of our body, our eyes, our nerves, our tendons, our ligaments, our fascia, where it's more extensible. And you're having then all of these secondary issues where you could have POTS, dysautonomia, which you can get dizzy and off balance, and your blood pressure and heart rate, everything goes haywire. Mast cell activation syndrome, where you're much more vulnerable, let's say, or even internally, where you're having what is perceived as an allergic reaction. Your body just goes haywire. I have all of the musculoskeletal issues with coming to a position of being too loose, right? Now, I always tell my folks with hypermobility, you can roll your ankle like a champ and not have, massive side effects. You just have to know your body, right? So if I rolled my ankle like they do on a daily basis, I would be broken in a wheelchair. Or if I could reach and grab a purse like that, I would dislocate my shoulder. They can get away with it until they can't. So a lot of it, actually, my hypermobile practice has gotten so much better because what I've learned from my wife with interoception, essentially learning how to teach somebody to perceive what they feel accurately. So how do I know I'm using the right muscle? Folks who are hypermobile are significantly burdened in a position where they do not know how to differentiate what they feel as well because they don't hit their end ranges as well. So that even goes with GI dysfunction. Usually they have GI, issues, energy issues, anxiety, stress. It is interesting how many people with hypermobility present so similarly with even past trauma, sadly.
Sensory integrated dysfunction.
Huge sensory integrated dysfunction. So that led us then to these were the folks that are failing everywhere else. So me being slightly stubborn and not enjoying not being able to serve somebody well, led to then a lot more research, a lot of figuring out how to help, which then led to participating more in this world and reaching out to the Ehlers-Danlos Society, partnering with Dr. Frank Amano, who's a geneticist, internationally renowned geneticist, and Dr. Tinkle. They're both up in Indianapolis. We're partnering with Dr. Leslie Russick, who's the #1 U.S. researcher in physical therapy for hypermobility. We're doing a couple presentations nationally at our combined sections meeting. So it's kind of led us to a really nice route. And the Specialty Center of Excellence was something we were extremely proud of. We were in the first cohort. We were the only PTOT speech only company to actually get the designation in that first cohort. And these are groups of like IU Health in Indy, Mayo Clinic in Jacksonville, Mount Sinai out in New York. So, it's one of those that we were kind of laughing when you scroll down the list, like, oh, there's Forefront Therapy. What the hell are they doing there? But, little fish in a big pond sort of deal. But I think God allowed us to step into some of those roles. And then we've kind of, taken that and run with it a little bit. Dr. Frank Amano, who's a geneticist I alluded to, and then Sarah Book, nurse practitioner who she works with, we set up a 3-day retreat with a really cool spread. It was these cabins in the woods called Bradford Woods. And we had a cohort of 10 women who with EDS, moderate functional ability. So none of them were wheelchair bound or anything like that. But we had 8 different lectures of all of these different specialists from IU Health and Forefront Therapy, GI, neuro, rheumatology, counseling, and then physical therapy. And it was cool. We started every morning with like a hypermobile friendly yoga session. Then we we had like one-on-one intensives with PT. And then we also had one-on-one with Dr. Frank Amano and Sarah Book from like geneticist, primary care influence. And it went really well. We actually just got published in the Journal of Rare Diseases, Diagnosis and Therapy section, just talking about that weekend intensive. And everybody loved it. We did a bunch of tests and ironically, even like what's called their Berg balance scale, where we assess their balance capacity. We never touched any of them. We really didn't do any sort of training, but they all improved in their Berg balance scale. So it just shows like sense of community, more education, and decreased fear. They were even more confident with their movement, which says a lot.
Amazing, you guys. That's a whole nother podcast. You're right. That's just fantastic. I love the work that you do. Thank you guys so much for being on here. We can talk to you for days and days and days. You have so much to offer. How can our listeners check you guys out? Social media, websites, stuff like that?
So you can go to forefronttherapy.org, but we're also on Instagram and Facebook. Yeah, you can reach out social media or our website or just give us a call. And
you all have, you check out your website, you treat pretty much everything. I mean, really comprehensive pelvic health. You do the FMS, athletes, all that jazz, which is really great. So, very trustworthy people. You guys are amazing. So highly recommend. So thank you guys so much for being on.
Thanks for having us.
Appreciate it. After all that, I think probably the thing we're most proud of are the people we get to work with. We've got a team of really, really sharp, hungry people that love helping. So thank you so much for having us on and inviting us. Really enjoyed the conversation.
You're welcome.
Thank you for listening to this episode of the Soul of Medicine podcast, where science meets soul for whole health healing. Are you ready to reclaim your energy, vitality, and soul purpose? Then feel free to head to our website at kcorpusmd.com and schedule an appointment for your root cause review.